Well, good afternoon. My name is Betsy Stewart, and I'm the Director of Advancement Communications here at LLS. And welcome to LLS Research Now, emerging research on COVID-19 and blood cancer. Before we get started today, I just have a few housekeeping items for us. Please note that this call is being recorded, and many of you have asked about receiving the recording. We'll send out that link to all participants after this call is over, either later today or tomorrow. All participants' audio and video is currently disabled in order to cut down on background noise. There will be a Q&A portion at the end of today's panel. You can ask questions during that time by typing into the Q&A feature. On your computer, you'll find the Q&A at the bottom of your screen. If you're on a phone or a tablet, you just tap the More button at the bottom of the screen on the right side, then hit Q&A. Many of you already submitted your questions when you registered. We have reviewed all of those questions, and we will do our best to address the most common and pressing questions in today's call. We know that we won't have time for all of your questions, unfortunately, but we are preparing a follow-up Ask the Expert call with Dr. Larry Saltzman, and you'll hear more about that later, so stay tuned. So that takes care of all of our housekeeping items. Now I'd like to turn it over to our host for today's call, LLS Chief Medical Officer, Dr. Gwen Nichols.
Thank you so much, and welcome to everyone. I'm Gwen Nichols, the Chief Medical Officer at the Leukemia and Lymphoma Society, and I'm pleased to welcome you to another of our series on the impact of LLS-funded research and really how your support makes all the things that we're talking about possible. We really couldn't do this without you, so thank you for your continued support. Today, we're sharing some very timely and important updates on COVID-19. And as all of you know, this is a rapidly evolving field. It is information that changes almost daily, and LLS has made a really concerted effort to make sure that the information we have on our website and that we provide to patients is as timely and as comprehensive as possible. But over the last 18 months, this has been an incredible upheaval, and we've seen vaccine approvals, recommendations changing, and we are trying to help all of you, your friends, your family members, stay safe. We continue to track these developments and work closely with wonderful researchers, two of whom are with us today. And I want to really thank those of you who are participants in the LLS Patient Registry. I will talk more about that, as will Dr. Saltzman later in our conference. But the fact that so many of you, we now have 11,000 blood cancer patients who have stepped up to be citizen scientists and part of this registry. I give you my heartfelt thanks, because none of us could answer these questions without the information coming directly from the patients and how important this information is. In July, LLS published one of the first reports of vaccine effectiveness and safety in blood cancer patients. And this would not have happened if patients didn't step up. And so thank you. I think this is important so we can provide you information, and important so that your doctors have information. That's how we do science. We want this information to be scientifically valid, and it happened with your help. I'm sure you know that the CDC recently issued booster recommendations, or third shot recommendations, for immunocompromised patients, which includes almost all of our blood cancer patients and many of our blood cancer survivors. This has been this CDC panel has been a really important step. And I'm so proud to say that LLS and our own Dr. Larry Saltzman testified in front of the CDC at the meeting where that decision was made. We could do that because we had the information, thanks to the LLS Patient Registry. So it's clear that your support, both your support of the registry and your financial support for LLS research, has made this possible, and we're using it to work for you and the people you care about. And at this point, many of you have probably heard me say this before, but LLS is really asking all of you to get vaccinated and act unvaccinated. And what we mean by that is that all of us need to think about others when we go out in the world. You don't know when you're standing next to an immunocompromised patient at the grocery store or the movie theater or a restaurant. We need everyone to wear masks, to continue to avoid crowded indoor spaces, to practice social distancing whenever possible, to minimize the chance that our blood cancer patient population will be at risk. And that means healthy people and caregivers and people who work with people who are immunocompromised need to act that way as well. So I thank you for doing that. Before we hear from our panel, I just again want to say at the end of September, this is the end of Blood Cancer Awareness Month, and this is a time for LLS to thank all of our supporters. This research, the registry, the two doctors you're going to hear from today have been supported because you make it happen. And that support is critical during these uncertain times. And now I'd like to turn this over to Dr. Lee Greenberger, our Chief Scientific Officer.
Thank you, Gwen, and thanks to everyone for joining the important call today. It's a privilege to speak to so many patients and members who've become part of the National Registry, of which Gwen, Larry, and I have worked very diligently and hard to assemble and get the information public. Over the last 18 months, LLS is taking a leadership role in convening work to understand the vaccination, blood cancer patients, and be an advocate for patients who have blood cancer and who might be immunocompromised. In addition to talking to two outstanding physician researchers who can reach on COVID and patient responses to vaccines, we'll get an update from the National Registry from Dr. Larry Saltzman. And I'd like to introduce our expert panel. So the panel to turn on their video phones. We introduce each of you introduce yourself, your institution, and a research focus. So I'd like to see Dr. Verma and Dr. K, if you could
Yes.
mics and your video at this time. Great.
Yes. Hi.
Wonderful. So go ahead, Dr. Verma.
Yes. Hi, everybody. Thank you, Gwen. Thank you, Lee. My name is Amit Verma. I'm a hematologist at the Albert Einstein College of Medicine in the Bronx, New York. And I primarily see patients with myelodysplastic syndromes and leukemias. And we are in the Bronx. We were particularly badly hit by the COVID pandemic last year. And we have published a lot of studies on the effect that COVID had on blood cancer patients and also the effectiveness of COVID vaccines in patients with blood cancers. And I'm happy to answer any questions.
Okay, Dr. K, can you introduce yourself?
Yes, thanks, Lee. It's really a great pleasure to be here on this webinar and to talk about our work in B-cell malignancies and our assessment of the responses to the COVID vaccinations, and also to talk a little bit about a trial that we are working on to use convalescent plasma in order to help prevent COVID infections. My area of expertise has been in chronic lymphocytic leukemia. I've been studying that for CLL for a very, very long time, probably when I had jet black hair. And so it's been a while. And most of my focus has been to understand the immunologic systems that are operational or not in CLL. And I think some of that has been important in understanding why some patients with CLL may or may not respond to the current vaccinations. So again, thank you for having me here, Lee. Appreciate it.
Okay. Tell us about what convalescent plasma is, why you think it's important, and how this topic became of interest in the pandemic.
Yeah, so the convalescent plasma usage in medicine has really been around for a very long time. It's been used to treat hepatitis A and B, varicella, various other viral infections. And the essence of it, the theme of this approach is that it provides immediate protection if this convalescent plasma contains antibodies against a particular pathogen. So it does not require the immune system to be revved up, if you will. The convalescent plasma, depending on the source that you obtain this from, usually it obviously is from patients who've been infected with a particular pathogen, have recovered, that plasma will provide protection for a variety of different pathogens. Now, in the case of of COVID, I've been working with the team here at Mayo Clinic that is very dedicated to developing a convalescent plasma where the convalescent plasma itself is obtained from individuals who've had COVID and have recovered. And this plasma contains anti-COVID antibodies. And it's a concentrated source of this anti-COVID antibody. And it will be, our plan is to administer this in intravenous form with not a very large volume, perhaps 50 to 200 ml. And the reason and the rationale for that is that we have such a high concentration of the COVID antibody that you can give a small volume and yet provide protection for individuals who may be at risk. Now, this is currently not approved yet. It's at the FDA, and we hope that it will be approved by the FDA. It will be for immunodeficient individuals who have B-cell malignancies. This usage of convalescent plasma has been field tested by a team led by Mike Joyner here at Mayo Clinic, and 1 unit of a convalescent plasma has been administered to over 20,000 individuals. And it was reported earlier this year by that team as being effective and safe. So we're excited to move this forward, Lee, where we have a particular product that is containing a high level of anti-COVID antibodies. And we're excited to think that this can be extremely helpful in preventing COVID infections for immunodeficient patients at risk. And again, particularly our focus here is on individuals with B-cell malignancies.
Thank you. I want to now turn towards a discussion about patients with chronic lymphocytic leukemia. And I know you're an expert in the field. Can you tell the audience about the results with vaccinations and the production of antibodies in CLL patients, and what's being done about it?
So thank you, Lee, for that question. First of all, I do want to thank LLS for being able to provide support for some of the studies that I'm going to discuss in the next few minutes. So we are conducting an observational study for patients with B-cell malignancies, including CLL. And this observational study is looking at individuals who are about to receive the vaccination, whether it be the Moderna or the Pfizer, and then obtain a blood sample after the first vaccination, and then subsequently after the second vaccination at 6 and 12 months. We are looking right now at the seroconversion, that is the antibody production, using a commercially available test that's from Roche, but we're also conducting additional tests looking at antibody production of neutralizing antibody using a test called CPAS, as well as looking at cell-mediated immune responses that include B and T cell specific responses to the COVID pathogen. The results that we've had so far for CLL, to answer the CLL question directly, are very interesting. There's a hierarchy of response for seroconversion, that is antibody production. So for CLL patients who have never been treated, approximately 50 to 60% of those individuals will respond with detectable antibody in the commercially available assay. About 20 to 30% of individuals who are currently on therapy will not respond effectively either to the first or second vaccination. In particular, it looks like individuals who've got anti-CD20 monoclonal antibodies have little or no response for about 12 months. So using that commercially available test, CLL patients have a hierarchy of responses. It's not that they may not respond, but if they're on therapy, particularly the novel agents or the anti-CD20, the responses are much less. In looking at the, if you will, more sophisticated test, the CPAS test, which looks specifically at neutralizing antibody, our current results indicate that about 20% of CLL patients will respond to the first vaccination, and then after the second have an even more vigorous response. About 20% who didn't respond after the first vaccination will respond after the second vaccination to some extent, but about 60% of our CLL patients do not respond at all using the neutralizing antibody assessment. We're currently in the process of collecting the cell-mediated immune results, but they're not mature enough to comment on at this point, Lee.
Okay, I'm going to move to Dr. Verma, but I just want, Neil, if you could just, what is the difference between antibody and neutralizing antibody? I think the audience needs a little more clarification.
Thank you for that. So the antibody that's detected by the commercial methodology that I just mentioned is a semi-quantitative method. It's detecting spike antibody, which is the receptor. Theoretically, it's the receptor that is used by the virus to get into the cell. But it is semi-quantitative. It's relatively crude. The CPAS test, which I mentioned, is measuring specific levels of neutralizing antibody that would theoretically prevent the virus from being infective at all. So it's a really much more incisive test in terms of telling us that the individuals made antibodies that will protect them from the COVID infection.
Right, so it's kind of antibody levels versus functional antibodies that actually supposed to do the job of blocking the virus. Thank you. Okay, so Dr. Verma, I'd like to turn to you. I know that you've been studying this almost since the inception, and I know, as you mentioned, the Bronx was really hard hit. You've published 2 papers in the field. Can you tell the audience about what you've learned from the 2 papers that you've published?
Yeah, thanks, Lee. The first observation was that when patients with blood cancers get COVID, and when I talk about these studies, keep in mind these were March, April, May months of last year, when the whole of New York area was extremely badly hit and the hospital systems were stretched enormously. So at that time, what we found was that when blood cancer patients with compromised immune systems were infected with COVID, they tended to have worse outcomes than patients without cancer. Gladly, fortunately, the experiences in March to May last year have become now way better. Now, even patients with blood cancers, when they get COVID infections, our outcomes are much, much better. We've learned how to take care of this disease. We are much more aggressive. We actually have more medicines to treat these patients. But what this research highlights is that we need to do something extra for our patients with blood cancers. Then we've looked at the next study that we did. We wanted to see if blood cancer patients do get COVID, do they make antibodies at the same level that is seen in non-cancer patient. And what we saw there was that if you have AML, acute myeloid leukemia, MDS, myelodysplastic syndromes, you do pretty well. More than 90% of patients with MDS and AML had good numbers of antibodies after they got COVID. The patients that weren't able to make their own natural antibodies after COVID infection were patients with CLL, transplantation, who received transplants in the past, CAR therapies in the past, or were on treatments such as rituximab that kills or targets CD20. And lastly, we, along with data from the LLS registry that was published in the same journal, our group also published experience with the COVID vaccine in blood cancer patients. And we saw similar results: MDS, AML, COVID vaccine, 95% production of antibodies. Patients with CLL, patients who've had transplants, patients who were on rituximab, it wasn't bad. It was about 60%, but it was less than some of the other subgroups that I've talked about. And I think in the future, we are now testing booster doses. And it was very heartening to see the LLS report that booster doses are working. Not for everybody, but for a substantial, I would say, majority of patients. And we are now testing the same thing in our clinics.
Great. So you mentioned the booster trial. We've actually published on 49 patients. I know so we did it as an observational trial. We used the registry, which is observational. You're doing more of a clinical trial, so you could track the patients more closely. When do you expect to publish results?
Yes, so thanks to the LLS for their support, which has been invaluable in doing this clinical trial. We have now enrolled nearly 130 patients. And after a month's time, we will know. All the boosters have been given. In about 30 days, we will know the results, and we will get the report out ASAP. As soon as we know the results, we can promise you we'll get it out to the public in a week's time. Early data does look very encouraging. We don't have too many numbers right now, probably also around 50, Lee, but we are seeing about 50% of the boosters are working. The patients who had very low antibodies or no antibodies do have positive antibodies after the booster dose. I can tell you that right away.
Yep, we're seeing pretty much the same thing, about 50%. Okay, we're going to come back to you, and I could see the questions rolling through here, and there's some important questions and definitions that we need to go through. We're going to come back to that. I saw a lot of questions about level of antibody, and maybe we'll just pause here a little bit, and we should talk about that. What does seronegative mean? And when you have a high level of antibody, what does that actually mean? I see this appearing over and over again.
Yeah, I can comment on that. So there are a few tests that check the levels of this antibody, and the antibody that's important is IgG against the spike protein of the SARS-CoV virus. In our hospital system, we use a cutoff of 50. So anybody with less than 50 level of IgG is considered a negative. Anybody above 50 is considered positive. And I can tell you that some people have antibody levels in the thousands, like 40, 50,000. We've looked at our numbers in blood cancer patients, and I would say 25%, the lower 25% are below 1,000. So I would say majority are actually above 1,000. But that's for the Abbott test that we do in our hospital.
Right. So Neil, I'm going to let you come back on because so Dr. Verma is doing the Abbott test and the range is different. Neil, could you talk about the Roche test for
Yeah,
which
so
the registry
the,
thinks?
the Roche test we use here, and like I mentioned, it is semi-quantitative, and I would make the comment that I don't know what a protective level is. I really have no idea. And we are paying attention to it, but if you read the literature and if you look at the data that's been published, it's unclear to me that there is a tipping point level that would say, okay, you are protected. I would agree with Amit that for the individuals that we've seen, again, this is more with CLL, if they have detectable antibodies, they seem to do quite well. In fact, we've noticed, and I mean, I don't know if you, maybe I could turn this back to you a little bit real quickly. We hardly see CLL patients being admitted to hospital for serious infections if they have a positive test. What that level might be, I still wouldn't comment on, but that's been our observation.
Right. So I just want to, for the audience, for the benefit of the audience, the people who are on the registry, our range, we're using the same test Dr. K is using. It goes 0 to 2,500. If you're seronegative, you have below 0.8. So it's a cutoff that the manufacturer has suggested. So it means very low, basically almost non-detect. Doesn't mean you don't have antibodies. It means we can't detect it. Okay. Okay, I'm going to move on to Dr. Saltzman, and we'll come back to some of this in a moment. So Larry, could you put your video on and join the call? There you are. Okay. So Larry, tell us a little bit about the registry. That's to start. And then tell us what the registry has shown in the initial analysis and the boosters so far. You're on mute, Larry.
Sorry, there we go. Thank you all for attending this. Our registry is meant to be a long-term study of blood cancer patients and their treatments, their outcomes, side effects over time to make sure that we are doing the right thing for the most people. Having said that, with the advent of COVID and the advent of vaccines, we took the liberty to ask people to share their records with us and then share their blood with us for antibody testing regarding COVID response to the boosters. As Gwen mentioned, we have about 11,000 people who have now consented to be a part of our registry, which is a fantastic number. Just to give you an idea of those 11,000, the largest group is leukemia patients. 3,700 leukemia patients have signed up, and of the leukemia patients, the largest group are CLL. There's about 2,600 CLL patients now in our registry. There are 2,500 lymphoma patients. The largest lymphoma group at the moment is follicular lymphoma with close to 600 people. And we have 1,000 myeloma patients as part of our registry. So we have a very large cohort. It's excellent. In our vaccine study, 8,500 people had consented to have their blood tested. And actually, we've run blood tests on over 7,000 blood tests have been run on people. And with the booster vaccines, and I'll get to results in a minute. But with the boosters, the CDC allowing immunocompromised people to get a third dose of an mRNA vaccine as of mid-August, we've now run 2,300 booster tests. And so the results split into two. One would be what happened to blood cancer patients after the initial vaccines. And as has been noted by the experts here today, actually about 75% of blood cancer patients responded to the initial vaccines and 25% did not. Of those 25% that did not respond, we're finding that most of it is due to treatments of blood cancers, only some due to the blood cancer itself. And with boosters, the good news is that of the limited set that we started with, as Lee said, about 50 patients, we found that 55% of people who did not respond to the initial two vaccines have responded to the booster. And again, the people who did not respond are limited by the treatments they're on. Anti-CD20, the kind of rituximab type treatments seem to be the most negative in responding to the vaccine. Now, we started our study published with 1,400 initial people, 49 booster patients. As we have continued to accumulate data and we'll report on that, the trends seem to be the same. And I think that's important, that the more data we receive, we're seeing the same response. Long answer to your short question, Lee. Thank you.
Thank you. Yeah, and I want to say, you know, I work with Larry extraordinarily closely. I think we speak just about every day on these results. And we are just so impressed at the patient participation in this study. And when we've asked questions, we get responses almost immediately in 24 hours from patients. So we just want to thank you about that. So I know you've had a large amount of your time you spend educating patients, educating physicians. Can you speak to why that's needed and what have been the most pressing things in terms of educating the community?
Gwen, you want to take that?
Sure. So I think that we recognized back in December that really no blood cancer patients were included in the vaccine studies. So when patients were calling the LLS Information Resource Center and asking, you know, should I get the vaccine? Is it safe? Is it effective? We couldn't answer the question. And we convened some of the experts, including the two you see here, to say, do you have any information on this? We were concerned that particularly patients with B-cell malignancies, the B cells are the ones that make the antibody, they wouldn't be able to mount a response. And patients were saying, my doctor doesn't know the answer. Now, if there's anything more frightening than your oncologist saying, I don't know what that is. So we realized that we needed to get information on safety and we needed to get information on efficacy and get it out to the physicians as soon as possible. So we made, you know, it our priority to publish this information, not just accumulate it and talk about it, but publish it in the medical literature, which is how all of us learn. You know, we were able to get this in a high-profile journal so that doctors could see this and react to it, along with, you know, talking and giving information. And we continue to do this. So every day, your data and your information and your continued participation continues to provide answers to questions that are coming up about the boosters, about booster efficacy, about how quickly the vaccine levels go down over time. When should a 50-year-old get a booster, and what is immunocompromise? So a lot of the questions that many of you are asking in the chat And in the Q&A are the questions that we are in the process of answering through looking at all this data.
Right. I want to add just three things briefly. One is that there are questions about, is a booster the same as a third vaccine? And let me just say that unfortunately, these terms are used interchangeably. And I think if you look at the initial vaccine schedule, they're now saying for an immunocompromised person who's just getting their first vaccine, let's say we're going back to baseline, they should have an mRNA vaccine at day 1. Depending on Pfizer, Moderna, they should have an mRNA vaccine at 3 or 4 weeks, and then another vaccine 3 or 4 weeks after that. In other words, it's a 3-dose schedule. And for people who've had vaccines months ago, they're talking about a third vaccine, AKA a booster. The terms are used interchangeably, and we apologize if there's any confusion. The second thing I want to say is in relation to the question, or why are we doing this and educating people? The fact is that initially we found that the results of studies showed that blood cancer patients who were hospitalized, especially in ICUs, did not do as well as, quote, the normal healthy population. So we took it upon ourselves to say we need to protect ourselves. And our motto at LLS has become, get vaccinated, act unvaccinated. And we believe that those of us, especially with CLL, and I'm a poster boy for it, know that our immune systems are not quite as strong. And so we need to educate people. The third thing I want to say, because there have been some questions in the chat, is that our registry has also undertaken a study on T-cell response, and we don't have the answers yet to publish. I will tell you that we have 550 samples now that have been analyzed by people, half who did not make antibodies and half who did. And we're looking at that data. It's fairly positive, but there is going to be a group of people who we call the negative negatives. And we're trying to sort out who those are, because that's really important for us to get that message out. And I hate to say stay tuned, but that's going to be coming. We're really frantically looking at that.
So that's a good jumping off point for the question and answers. Dr. Verma, Dr. K, come back on. I'm going to stay off video because my transmission is not good, but I'm here. I want to talk, we've seen a lot of questions about T cells and antibodies. What do these mean? What do antibodies do? Why are T cells important? Why do we need to look at this? Why haven't we looked at T cells yet? And what is all this going to mean?
Maybe I can start, Lee. I just want to comment on CLL more specifically, because that's what I study mostly. To answer your question about what is an antibody, what is a T cell, in order to mount an effective immune response for a normal individual, a healthy individual, you typically will have a concert, a beautiful synchronized concert where antibodies of high affinity for that pathogen will be produced. And it will be highly specific for that pathogen, but over time it will diminish. The half-life of a normal immunoglobulin is around 30 days. And we do know that these antibodies will diminish over time. But the beauty of the immune system, again, an immunocompetent individual, is that the T cells become part of the immune response. These tend to be long-lived memory cells. They retain that memory, and they will respond on future challenges to that pathogen and can provide long-lasting protection. So we do need to know about T cells as well as the B cells that make the antibodies. In CLL, because of the nature of the disease, and it will be true for other B cell malignancies, the immune system is replaced to a large extent by the leukemic B cells. So there is a deficit in the ability of that immune system to be as replete as I just described. Now, there is a get out of jail card that I want to mention. The get out of jail card is either to consider for those individuals not mounting a response to think about monoclonal antibodies that can help that person. There's a Regeneron opportunity. There have been some other clinical trials with other companies have published now that look very, very good for antibody protection. And from the standpoint of the trial here that, as mentioned, was being led by Mike Joyner, along with Samir Parikh, these convalescent plasmas may be the get out of jail card. They're even if the individual doesn't mount a response, we are betting, calculated bet, that these antibodies will provide significant protection. It needs to be proven, but I think there is hope out there. I don't want people in this very important webinar to come away thinking, if I don't mount a response, am I going to be masking and distancing for the rest of my life? There may be other opportunities. Thank you for that.
I think maybe it'd be helpful if Dr. K or Dr. Verma talk about the difference
Trigger
between
off a question I've seen.
using the antibodies for prophylaxis versus treatment of COVID exposure. Because I think right now there's a lot of confusion and what's actually approved. And people are understandably concerned, and we're just saying, if you have any risk of exposure, do this. So if you both would comment on that, it would be great.
I can just quickly comment, Meet, please jump in. We do not have definitive proof via a clinical trial that convalescent plasma will be effective in prevention. I think there is significant data out there now that convalescent plasma helps to ameliorate the level of severity of individuals with COVID. And, I think that's where it is. We have a lot. We're very keen to go on and get these trials done that can show prevention. But I don't believe we're there yet, Gwen. Amit, do you want to?
Yeah, I think conceptually it does make sense that if you're in a vulnerable group and you're not able to mount a good response to the vaccine, then giving the antibody cocktail, either convalescent or using Regeneron or one of these approved antibody cocktails, will protect you from severe COVID infection. The problem is that the half-life of these antibodies is not super long lasting, and you do need to get this every 2 months, is what my infectious disease colleagues have told me. We have considered these requests on a case-to-case basis. The FDA approval is not yet for preventative mechanisms, and it's for treatment when you get COVID. But this is a rapidly evolving field, as we know, and I believe if there is a clinical trial which shows significant benefit of a preventive approach, it should probably get approved in the future, I'm hoping.
And certainly you as doctors can try and prescribe this for people who are at high risk of exposure. For instance, if you are seronegative and an elementary school teacher, you can get requested to get this in a preventative fashion. But right now, it's really approved for documented exposure.
Yes, Gwen, there are several of my patients where I've applied to the Regeneron. There's a website, and you can go through the drill of, I'm sure Amit's probably done that too, and it's available. But it's a little laborious. It's not a knee jerk. It's not like going to the pharmacy and give it to me. And I also would make a plea that we're hoping to get these trials done. I would encourage the participants to be contacting forgive me for the political statement, the people in the government who have influence on the FDA, and we need to get these trials done. And that we should not be delaying. It's been a while since our own trial has been at the FDA. I'm not proselytizing our own trial. I'm sure there's plenty of other trials out there, but we need to get these trials done so that we can prove that prevention is effective. I do agree with Amit that the half-life of these antibodies may be somewhat time limiting, but at least then we'd have several approaches to take care of our patients.
Yes, and I might add one more potential approach. So if you've had 2 doses and then a booster as the 3rd dose and still don't have a good IgG level, we are in the process of opening a clinical trial with the support of the government, the National Cancer Institute, where we will give a 4th dose, and it'll be a randomized study. So the 4th dose will either be the same vaccine that you've received before versus switching it to a different vaccine. And the thinking is maybe by switching to a different vaccine, we might be able to mount an immune response. But that trial should be starting very, very soon.
So we know that 25% of the patients are not going to make antibodies. And you've both talked about, well, if you're not making antibodies, you might be at risk and maybe even a candidate for a booster or the antibodies. But not everybody's going to be able to do an antibody test. So how do you manage this? I mean, surely, you see patients and you could do an antibody test. That's not true for everybody. What should people do? One could say, well, maybe I've been exposed. What should I do? How many antibody tests do you perform? Should we do it? Those are my questions.
That's a great question, Lee. And till a few weeks ago, it was tough to get an antibody test, even for us and even for inpatients. Things are becoming easier. There are commercial labs that do test it. I think if you've had a negative, so let's say you have a blood cancer or you're on Rituxan, had a transplantation done, a solid tumor, or a solid organ or bone marrow transplantation, then I think it may not be a bad idea just to see if you have a good level of the IgG. You go to the hospital, your clinic, your doctor's clinic, or outside lab. I think most of them are doing it now. And then if you are still negative, then I think consideration of a booster dose, a clinical trial, or an antibody, if it gets approved, is not a bad idea. So if you're in a group of people that have not mounted great responses, then having it checked is not a bad idea. On the other hand, if you have no concerns, the most people mount antibodies at 95% plus efficacy, then I don't think you need to get this IgG test.
Okay. I've seen a lot of questions about rituximab. Why is it that the rituximab, you could have rituximab 6 to 12 months ago and not make antibodies and be at risk? And if patients need rituximab maintenance, what are they going to do? How do you address that?
Excuse me, I can take that on initially, Lee. So for CLL patients, the use of anti-CD20s is very, very common. Even in the area of novel agents with ibrutinib or acalabrutinib, which are novel agents against the BTK molecule, very important signaling pathway in the B cell. The rituximab or other anti-CD20s, obinutuzumab, ofatumumab, we're using them frequently because in combination, they work very well and they help to control the disease. Unfortunately, they also get rid of normal B cells very effectively for a long time. And my understanding of the current data, and our own data suggests this, is that if a patient has a rituximab infusion, they're probably not going to respond for at least 12 months. And that's an unfortunate consequence of this therapy. Our current practice is now that if we have a patient who is going to go on therapy, they have not yet been vaccinated, we do the vaccination first, and then administer the rituximab whatever the anti-CD20 is. But unfortunately for many, it's after the fact, and there isn't much that can be done to take that individual out of that space, which is a risky one, except to go back to masking, social distancing. As Larry has said, we need to be continuing to do that. And then, of course, the option of the commercial monoclonals that should always be discussed with the caregiver.
Okay. Neil, I have another question for you. So CLL patients, we know about 30–40% of them are not going to make antibodies. Some of these patients are just on watch and wait. They're not even getting any therapy. And so what do you think about that? You know, should some of these patients say, well, I'm not on any therapy, I'm basically fine? Are they?
Well, they're probably better off than if they were on therapy because their immune system may be at a higher level than if they were being treated. So that's one answer to that question. The other possibility is that, the median age, if this is CLL, is 72. And we know that as we all get older, our immune system doesn't kick in as avidly as when you're 20. So they would be at risk just because of the disease itself and also their age. And of course, other comorbidities, if they happen to have other diabetes or other chronic diseases that could diminish their response. If they're on prednisone, that could diminish their response. So it's kind of a complicated situation for a given patient. The one thing I would suggest, and it gets back to what I think Amit has said and also in his upcoming clinical trial, if they've been vaccinated with the standard 2-dose, it may be good to mix it up a bit. If they've gotten the Pfizer, maybe they should get the Moderna. It's appealing to me that if you give a different vaccine, you may still rev up your immune system to seroconvert. So I like that trial that Amit's doing. And maybe patients should be thinking of going on that clinical trial because that's an option, especially if they're not going to be treated, that might be a very nice option.
Right. That sort of brings me to the next question. And we've seen a lot of questions about which vaccine is better, Moderna, Pfizer, J&J. And you yourself, Amit, have published data to suggest that Moderna can produce more antibodies than the Pfizer vaccine. Is there a difference? Is it meaningful? What should patients do about it? I don't know if you're going to answer that, Amit, but you're on mute.
Amit, is that me?
No, Amit, you're on mute.
Lee, for some reason, my computer malfunctioned. I could not hear the last part of your question.
So the question is, you've shown that Moderna and Pfizer are have different abilities in terms of producing antibodies.
Yes.
Are there any differences, real differences in terms of protection? Should
Yes.
patients select one or the other? What's your opinion?
It's a great question. Your study, Lee, showed the same thing as ours, that the amount of antibodies quantitatively were more after the Moderna vaccine in cancer patients as compared to the Pfizer. Now you're saying, does that correlate with protection? And we don't know that. Luckily for us, after the crazy days of last year, we've not had too many COVID infections in patients. And patients who've been vaccinated, this is very, very rare, even in our big hospital systems, to see breakthrough infections. So we don't have enough of a sample size to say that. You can extrapolate that more antibody in your blood, maybe better protection, but that's all we know so far.
Yeah, I just want to add that in our study, which is observational, we actually are finding that patients are mixing and matching vaccines. And so, although we're not in an absolute clinical trial, we are looking at the responses as we receive them. And as Amit noted, and we've said, there seems to be just a smidge of a difference between Moderna and Pfizer. And so, as Dr. K said, adding a Moderna vaccine as a third shot is really a consideration. we think.
Okay, well, we have 5 minutes to go. Gwen, I'm going to leave it to you to wrap up.
Yeah, I wanted to mention one thing before we wrap up, and that is that, there is a lot of information available, and people who might be looking for how to find Dr. Verma's trial or to hear more about Dr. K's research as it comes out, and to hear more about what we're learning in the registry and what we've already learned. I know you're not all getting a subscription to Cancer Cell and reading it cover to cover. Neither are we. So we have all of it on LLS.org COVID-19 resources. And there's a new web page to make it more easy to find some of these answers. We also, in terms of clinical trials, will post any important clinical trials, and we have clinical trial nurse navigators who can help you find those trials as they are available. Thanks to everyone. Thank you, Dr. Verma, Dr. K, for joining this call. I really want to thank everyone for being here, and I hope you feel that your participation and your support has been pivotal for the answers that we do have. Even though we don't have all the answers, you know that there are really wonderful physicians and researchers out there helping LLS try and answer these questions. I want to invite you to join us again on November 5th. The topic is another very timely one. We're going to be talking about healthcare disparities, and specifically on a new research program at LLS that focuses on addressing equity in access to blood cancer care. So you will receive an invitation soon. And so I will officially end our call. Thank you all for attending.
Oh.